Well, good afternoon, everyone. I'd like to welcome you to HHQI's Underserved Population Networking event. I'm Misty Kevich, one of the RN project coordinators, and also joining us from the HHQI team are Crystal Welch, Sharon Miller, Misty Dyke, and Andrea Lefke. So let's do a few housekeeping points before we get started. The slides are posted on HHQI's website. You'll also we'll put into chat box for you the location of where the slides are located in just a second. We do ask for you to submit any questions throughout the presentation through the Q&A tab or on chat. All the lines are muted to avoid background interference. So we really want you to send us questions throughout the presentation. We do have a place after the speaker has finished to address as many questions as possible. And if you've been on some of our calls before, you know we tend to run out of time, so get your questions in early so we're not getting those right at the very last minute. So I don't want to wait any further. I'm very excited. So let's turn to the next slide and get started with today's webinar on long-term negative effects of trauma. We're very appreciative of having Karen Yost with us today. Karen is the current Chief Executive Officer of Prestera Health for Mental Health Services, which is in West Virginia. It is the largest behavioral health provider of the state. She previously served as the Director of Clinical Services at River Park Hospital for nearly 15 years and was the Director of Shawnee Hills Children and Family Services. She has been recognized with the 2010 Michael Prestera Award for Excellence for 2 decades of service, leading to improved delivery and availability of mental health and substance abuse services in West Virginia. Karen also serves as an adjunct faculty to Marshall University's Counseling Department and provides many educational seminars throughout the country. So without any further ado, I'd like to introduce and turn it over to Karen Yost.
Thank you very much, and it is a pleasure to be with you today. West Virginia has been, over the last couple of years, undergoing a significant amount of work in trauma and the impact of trauma on many of the individuals that we serve, and that's what we're going to talk about today. And we're talking about developing a trauma-informed care and our systems, a trauma-informed system of care. So when we look at the picture on the right at Anna at age 1, how cute she is, just a child and her whole life ahead of her. And this is Anna years later, living in a mental institution. And one of the things we have to ask ourselves is what happened to Anna during that time period? And what happened to Anna was a lot of trauma. And we talk about trauma, we're talking not about emergency room trauma and physical health trauma, but we're talking about emotional shock that really creates within an individual who experiences these experiences significant and lasting damage. And it can have an impact on their emotional and behavioral health, their physical health, and growth through the lifespan. And traumatic experiences, we know over time, can have such a significant impact that they really do affect someone's safety, well-being, and permanence. And that has long-lasting effects all through the lifespan and even, in fact, can shorten the lifespan. Because what can happen when people experience trauma is that it affects the way they look at themselves, it affects the way they look at other people, and their environment around them, and really changes how we view what's going on in our world. And of course, that changes how we react and respond to our world. So I'm not going to read all these prevalence statistics. You can find them anywhere, but I give them to you just to show you that when we're talking about traumatic experiences and trauma, that it isn't just one group of individuals. And a lot of times, I know when I started the field and you talk about trauma, you think primarily of child abuse and neglect. that is not the case, as you can see by some of these prevalence data. And one of the newer statistics is around disasters and how people who experience national or man-made disasters respond, and that 100% of them likely will experience some form of trauma if it is just around shock of the experience, but that 25 to 30% of those individuals will develop full-blown PTSD. So it isn't just about abuse and neglect, but it is what many of us experience in our lives. That was exactly the case for me in 1977. My entire county, my home county, was washed away by a flood. And we certainly lived the impact of that extended throughout at least a year, and for many individuals a lot longer. And the impact of that caused them to leave the area and relocate. Here are some vulnerable populations. Everybody is certainly vulnerable, but we do know from our research and what we see in many of our systems that there are some populations a little bit more vulnerable than others, and this is a list of them. One of the things that we're just now really coming to understand is the staggering financial burden to society. And here are some statistics around just childhood abuse and trauma. And these are statistics for the United States, and there are a lot of, in your resource section and work cited, some of the citations are there. But direct annual costs for hospitalization, mental health care, and your child welfare system and medical care is $361 billion in the United States annually. And then you have indirect costs, which are things like lost productivity, which is estimated at $64.4 billion. And then you take into consideration things like special education, juvenile justice for children, and the criminal justice system, and those costs are even more staggering. So this is not a small problem. This is a problem that is actually a public health problem that has far-reaching effects on the financial situation of our society. So we talk about trauma, and what is trauma really? And there are a lot of definitions of trauma. Well, it isn't really a diagnostic category in the sense of how we're talking about it today. And there's no real universal definition of trauma because it's defined by the person themselves and how they perceive the experience. So it's different for individuals. But in general, when we talk about trauma, we talk about an experience or a series of experiences that elicits some very powerful feelings. We're talking about could be terror if the traumatic event in my case was a flood, which had threat to life, powerlessness, which you frequently see in many different traumatic experiences, out of control, psychological arousal, and those experiences can result in survival-driven behaviors, thoughts, and emotions and needs versus how we typically solve problems every day. So it changes the way we view our world, and that changes the way we respond to our world. One of the things that makes trauma very complex is it is often misinterpreted and assigned as symptoms of specific disorders. For instance, depression, bipolar, ADHD, oppositional defiant conduct disorder in children, and attachment disorder, because many of the sequelae of trauma does have behaviors that fit within that diagnostic category. And so we label and we give syndromes to people when, in fact, even though some of the symptoms may be consistent, it's really trauma that is driving what's going on. And many of these diagnoses generally do not capture the full extent of the impact of trauma on people's lives. So we see how it happens, but it doesn't quite capture it. And when you're talking about exposure to trauma, trauma can be a single event. In my case, it was a flood. It can be a connected series of events, and that could be something like a child abuse, neglect, domestic violence. Those things tend to happen over time, frequently, or not just one event. And they can, in fact, create chronic stress. And trauma is underreported and underdiagnosed. Again, we call it a lot of other things, and it presents either as a behavioral health issue, it can present as a physical health issue, it can present as a lot of issues, but in fact, it is very much underdiagnosed. We don't recognize that it is trauma. There are different types of trauma. For instance, acute trauma, the flood in my county was a single traumatic event. It happened over a period of days. The floodwaters went down, and there were no more danger to life and safety. However, we have to deal with everything that follows behind, finding housing for individuals and not having resources and just the fear every time it rained. So that was one event. That was a single traumatic event that really lasted over time. Chronic trauma is the experiencing multiple traumatic events. So you could have an example. I'm driving to work and I have a presentation to make and I'm running late, and so that's kind of stressful for me. On the way, I get a flat tire, another stressful event. I'm trying to hurry from that because I'm already late. I get stopped for speeding, another stressful event. So we're talking about experiencing multiple traumatic events over time that may or may not even be related. Now, my event would have happened in a short period of time, but it just gives you an example that many of these traumatic events may or not be related and can occur over a period of time. Then you have what I always knew, but I didn't know the name for it. We have system-induced trauma. And you see that quite frequently for individuals who are interfacing with many of our systems, particularly the best example I can give you is child abuse and neglect. For children who are experiencing abuse and neglect in the home, a social worker comes in the home or goes to the school, pulls the child out of the home. The child doesn't get to say goodbye to mom, dad, brother, sister, Spot the dog, ends up going somewhere to sleep tonight and have had no say in it, no preparation for it, don't even know where it is. So they have to adjust to all new rules. They are going to have to perhaps go to court, which can also be traumatic, or they get placed in a hospital or residential facility, a detention center. And sometimes those events can happen over a period of time. So our systems that are designed to support, protect, and serve many of these vulnerable individuals can, in fact, induce system trauma as well, because removal of a child from the home is traumatic. For me, if I have to travel somewhere, I want to know where am I going to stay and where am I going to park. I always get very nervous when I have to go to different places because that's a little stressful for me. I cannot imagine being pulled from my home with no preparation and having to spend the night with people I never knew again. So our systems can, in fact, re-traumatize to an even greater degree, oftentimes, already traumatized individuals. And then you have complex trauma, and that is for individuals who have exposure to chronic trauma, and the resulting impact of that trauma can be very significant. So that creates complexity for individuals that can be very difficult to treat. So let's go back and talk about traumatic experiences. Again, you know, a lot of times when we think of trauma, we think of such things as abuse, neglect. We think about loss of loved ones, death in our family, which could include a pet. We think about war, which the field of trauma and PTSD really began within the military, especially after Vietnam. So what we now know is that the traumatic events are much greater than those, and it still includes those, but we talk about things like accidents. We talk about homelessness and the impact of homelessness on individuals. Certainly community and school violence, which in many cases is on the rise. Bullying for children and particularly cyberbullying, which really I think is horrendous and much more impactful even than regular bullying that I grew up with. But we know from many of the school violence events that we have that when they begin to really look at what happened, a lot of those stemmed from bullying in schools and children who felt different and were bullied by other kids and it was never recognized or addressed. Frequent moves for many of the children, particularly having to, I've worked with children that have been in 43 placements in their lifetime and at a young age. That's pretty traumatic. Medical illnesses, particularly illnesses that may be terminal or very significant for people that are not allow them to go to school or really impact their day-to-day functioning. Certainly you have abuse, neglect, natural and man-made disasters. For me, it was a flood, my first one. The second one, 9/11, certainly had an impact on everybody in our country. That was a man-made disaster. And if you think about 9/11, people generally remember exactly where you were when you heard about it. How many of us stayed glued to that television set, and how many times did we see those towers fall over and over and over? And the impact on children who continued to see that, who did not understand the context of it, was very significant. We had a lot of individuals with some pretty significant symptoms after 9/11. Witnessing violence, it could be, we have vicarious trauma, domestic violence certainly falls into that, acts of terrorism and refugee and war zone trauma. So when we're thinking of trauma, it's a lot of experiences. And this is not an all-inclusive list, but if you look at this list, ask yourself, how many of you have experienced at least one of these? Most of us probably have. In fact, the research shows the majority of individuals have experienced at least one, particularly by the time you reach adulthood. Many of us have experienced more than one, and right on up the ladder. I did count mine, the things I've experienced that I consider to be traumatic, simply around loss of loved ones, and going away to school was traumatic for me because I left a very small community and went to a very large school. And really studying at 7 or 8 by the time, you know, the loss of my grandparents, loss of my parents, loss of my husband, you know, that was 7 people. So we've all experienced many of these. And the point in this is that none of us are immune to traumatic experiences. And we experience them at any age. You know, young children can lose grandparents, can lose pets, have traumatic experiences, all the way up to our older folks who are realizing that they are losing their independence, and many of their spouse, their friends begin to die, and how traumatic that is. So it happens across the lifespan, and it can be anyone. So there is no, it affects everybody in our society, not just a population. One of the things that really highlighted the impact of trauma was the ACE study, and the ACE study was the Adverse Childhood Experiences Study, and it was begun by Kaiser. And what they looked at was the impact of adverse childhood experiences on adults, and throughout the lifespan? And was there, in fact, a correlation between childhood trauma and negative consequences later in life? So it was a very large study. And in fact, what the study found was that absolutely there is a correlation between adverse childhood experiences and negative consequences in later life. And the pyramid that you see before you really just talks about some of those things. For instance, social, emotional, and cognitive impairment. We'll talk about that a little bit more in a minute. The adoption of high-risk behaviors, leading right on up, depending on the whole life perspective, leading to physical diseases and social problems. We're talking about disabilities, we're talking about substance abuse, we're talking about cardiac, we're talking about depression and mental illnesses. And for some of those individuals who have, in fact, experienced multiple traumas and for whom those traumas have had a significant impact, can in fact lead to early death. We do know that individuals who have severe and persistent mental illness tend to die 20 years sooner than other adults. So not only is a small problem, but in fact can have an impact on our lifespan as we grow older. And that was the first study that really demonstrated that in a quantitative way, that yes, indeed, what some of us who are social workers and health professionals, particularly if you work with children, already knew, but we couldn't quantify it, and we didn't have research to support that. And the ACE study did exactly that. And there's a lot of work going on with regard to the ACE study and implementing those questions into our assessments, which we will talk about in a minute. So some of the, in looking at the adverse childhood experiences, we're talking in the physical health domain, they found a correlation between these experiences and individuals who had higher risk of heart disease, chronic lung disease, many of these folks smoke, liver disease, which may be related to alcohol use, diabetes, cancer, and certainly autoimmune diseases. That's a little different than we knew it had an impact on our emotional and behavioral health, but what this study showed very clearly is it is not just our emotional and behavioral health that is impacted by these childhood experiences, but in fact, they can have a significant impact on our physical health as well. And one of my activities has been to serve on panels for individuals in college who are getting degrees. And when I taught counseling classes and I taught stress management, which I think should be a requirement, I began to notice that half of my class were cardiac rehab majors. And I thought that was odd. I thought, why do I have all these cardiac rehab majors? I'm expecting psychologists and counselors and social workers and all that, but I began to have far more cardiac rehab, and then I began to be asked to sit in on their orals. And come to find out, as I began to explore it, for heart disease, there were 3 strategies for dealing with heart disease, and one certainly is exercise, one is nutrition, and the other is stress management, which of course we all knew. But now in academia and the universities and in physical health programs, they're really beginning to see that there is a correlation between behavioral health and physical health. And a lot of questions about what are we going to do about it? How do we address these? Because we may not be trained to do that. So this study showed very clearly that there are very significant impact of adverse childhood experiences on physical health. Now the behavioral health realm, let's look at that. That's what I know. I'm a therapist. So in the behavioral health realm, we're talking about increased mental illness. We're talking about relationship problems. Many of the individuals I've worked with all my life have a very hard time developing and maintaining positive relationships. Behavior problems in children and adults. I've worked with a lot of adults that seem to have a lot of behavior problems. For many of these individuals, poor self-esteem, and that can also lead to them putting themselves in situations that tend to perpetuate that. You see that sometimes in domestic violence situations. Certainly an increase in substance abuse, because many of these individuals we know now began using substances to self-medicate all the pain that was caused by trauma, although they didn't always know it. And so now much of the work we do with individuals with substance abuse is to train them about traumatic experiences. And you can see individuals start to make the connection. Other high-risk behaviors certainly are suicide, which is a leading cause of death in children, also older adults. And you see the increase in suicide for individuals who are hopeless and helpless, and all of those things. So it's very clear now, the research is very clear, that adverse childhood experiences can have a negative impact on physical health and emotional and behavioral health throughout the lifespan. So what does it mean? What does all this mean? An ACE score, and it's an assessment. You have a certain number of questions and you answer them. We use 10 questions, and you get a score based on the number of adverse childhood experiences. So with an ACE score of 4 or more, which in my case was more than 4, the majority of these adults are at significantly higher risk. There are higher risk factors for these diseases and for health risk behaviors. Obesity, substance abuse, and those kinds of things. So we know that based on the research that's been done, that the higher the ACE score, the higher the risk factor. So here are some other ACE study facts. Adults with an ACE score equal to or greater than 4 are 460% more likely to have a lifetime history of depression. Now, the history, you may not be depressed all the time. It can come and go, but throughout the lifespan. Adults with an ACE score of 5 or greater are 16 times more likely to have a lifetime history of alcoholism. A male child with an ACE score of 6 has 4,600% increase in the likelihood of later becoming an IV drug user. So there are very strong implications and very strong support to tell us that we need to address these traumatic experiences beginning in childhood, because they will experience sequelae of that perhaps through the lifespan. So when we're working with individuals, we need to be asking about this. So the question to ask then is, what does trauma do to us? Okay, we know based on research that it can have an impact, but what does that look like? Chronic trauma can interfere with our neurobiological development. And what that means is our ability to integrate, which is the function of the brain, which is to integrate sensory, emotional, and cognitive information into a whole, attach meaning to that, and then respond to that. There are studies of brains of individuals a lot of PET studies of individuals who have experienced significant trauma, and they're different. And so the normal development, the neurobiological development, can get delayed. And so many of these individuals have developmental delays in the ability for the brain to function things. And of course, we know with the brain, the cortical part of the brain is the thinking part of the brain. And when this neurobiological development gets stunted, that part of the brain that allows us to process and assign true meaning and respond in a logical, rational way gets impaired. So it sets the stage for us who have these issues to respond to subsequent stress in unhealthy ways, because it changes the way we look at that. And we're going to talk about that in just a minute a little bit more. But in the areas of overall development, trauma can cause impairments in many areas of development, such as attachment, our ability to relate and to empathize with others, and to develop meaningful and lasting relationships. Because if we look at the world as if it's unsafe and if it's unpredictable, then we respond that way. And so we're not going to make ourselves more vulnerable to that, so we just withdraw. And we see that a lot of times with children who do not attach to individuals very well because it's too scary and it's too unsafe. So the safest thing for them to do is not do it at all rather than to be heard. Biology, many of these individuals have problems with sensation and movement, hypersensitivity to contact, insensitivity to pain. I've worked with a lot of children in psychiatric hospitals and residential treatment centers, and many of these kids don't feel pain. Some of these kids are self-abusive in order to feel something. So their physical symptoms, you know, they either, we have my head, my throat, my foot, my belly hurts. So there are a lot of somatic kinds of complaints, which now makes sense when we know there's a physical aspect, a biological aspect of trauma, and a lot of increased medical problems. So we see those for some time. Our ability to regulate our mood. Many of these individuals do not have a good way to identify what their moods really are and controlling those emotions and internal states. And so they tend to be hypervigilant, tend to always be in the state of fight or flight, and do not know how to regulate those moods. Behavioral control, certainly, poor impulse control, self-destructive behavior, aggressive, dangerous risk-taking behavior, suicide, drugs, running, obesity, all those kinds of things. People are not able to control their behavior well. And then dissociation, a feeling of being detached, and sometimes as if observing things happening around them and them not really playing a part in it. All of those we can see in these individuals with trauma. The ability to learn. I've worked with children most of my life, and I've always worked with traumatized kids. And one of the real challenges for many of these kids is to be able to function in school. We want kids to go, we want kids to behave, we want kids to sit still, we want kids to learn. And many of these kids just don't have a good ability to do that. They have a hard time focusing. Many of them are too busy scanning the environment to make sure they're safe. They have a hard time completing tasks. And a lot of these kids have significant learning disabilities and problems with language development. Many of these children do have higher prevalence for special education programs. And if you think about a child who's living in an abusive home or a chaotic home, how do we expect them to go to school and sit and be good and learn? For many of these kids, those are the safest places for them. But what we're asking them to do, their brains just don't allow them to do that. So we see a lot of cognitive problems with many of these individuals. Self-concept, feeling shame, feeling guilty, low self-esteem. Some of these individuals have disturbed body image, and that leads to things like obesity. It could also lead to eating disorders. Loss and betrayal, feeling that part of their lives is lost. They don't trust others. They get used to losing. And sometimes for these individuals, act in ways that reinforces that. Children particularly who have power and control issues will blow a perfectly good placement because they think they're going to lose it anyway, but they want to do it on their own terms. We're just working with a child this week that's exactly what happened. And then ultimately people feeling that they're victims and that they have no say what's happening to them and they're unable to control their lives. You see that also a lot with adolescents, and you know adolescence is that crazy time anyway, but a lot of these kids really engage you in power struggles. It's part of normal development, but it's power struggles in warp speed. For some of these kids, it seems like everything with them becomes a power struggle. And that is related to the fact that the truth is for many children, they don't have a lot of say-so in what happens to them. They have parents trying to tell them what to do. They may have siblings trying to tell them what to do. They have teachers telling them what to do. They have a child welfare system. They may have a court system. A lot of people are trying to tell kids what to do, and what they want to tell us all to do is just go away and leave me alone. So you see a lot of powerlessness in many of these individuals, and then they engage in ways to try to grab some power. So we know that trauma is a disorder of the brain, and it has serious consequences. We just talked about some of those from normal development of brain and how the brain, the chemistry within the brain and the nervous system. And that these alterations affect our biological stress response and ultimately change the way the brain functions and all the many things we just talked about. Because individuals in stressful situations, and we're talking about stress, we're talking about chronic stress here, result in increased levels of stress hormones, and how we respond to our perception of what is stressful within our lives. And our brains really are designed to give us what we need when we need it. For instance, if someone comes up behind you and jumps out at you and scares you to death, you may jump, you may scream, you may want to turn around and punch somebody, because we have that fight, flight, or freeze, which is what we have similar with animals. And that's the lower part of your brain stem, and that controls your everyday functions. You don't have to remind yourself to breathe in the morning when you get up. The middle part of the brain is the limbic system, and that part of the brain is the part of the brain that controls our feelings. It's where we experience pain. It's where we experience pleasure. Then the top part of the brain, the cortical part of the brain, is where we make rational decisions, where we look at things and decide, ooh, this is a bad choice, don't make this choice, do something else. When you're under traumatic stress, the parts of your brain that are engaged are the fight, flight, or freeze, the brainstem part, or the limbic system. So that's where we have all these emotional reactions and things that way. But the part of your brain that allows you to think and make rational decisions doesn't get engaged. The other two parts of the brain are engaged. And so when individuals perceive their world as unsafe and are always hypervigilant to ensure their safety, the part of their brain that's engaged is the fight, flight, or freeze, or perhaps the limbic system. So the ability to think and make rational decisions, that gets overridden by the part of the brain that is about fight, flight, or freeze, or the limbic system, the feeling part. And that's why we see changes in the chemistry of the brain. So the brain's ability to have the crosstalk between the hemispheres doesn't occur to the extent it should. So that's where we have the emotions and managing our fears and the sustaining of attention for learning and problem solving, and all these problems that we have is because our brains aren't fully functioning. The part of our brain that allows us to think and do some of these activities doesn't get engaged. But the other part of that is that wear and tear, that causes wear and tear on our bodies, because our bodies aren't designed to do that over the long haul. It comes in sudden bursts. But when our brains are engaged in those types of activities for long periods of time, it creates within our brains and our bodies wear and tear that ultimately leads to some of these physical health problems that we talked about. So how we perceive trauma is based on three things: the event itself, and we're talking about the circumstances of the event, the threat of that, of harm or potential of harm. In my case, I'll use our flood as a case. It was a significant event, and there was a very strong threat of harm. How we perceive that experience can be different. All of us have different types of coping skills and different levels of coping. So how we perceive that event can affect the kind of trauma it has for us. If we perceive it as, this is a terrible thing that happened and eventually I will feel better, that has a very different impact on us than, oh my gosh, I'm going to live here forever and it'll never get any better. So we all perceive events, a particular event, our brains assign meaning to that. And depending on the type of meaning we assign to that experience and that event and how we experience it, then can in fact change whether we experience that event as traumatic. And two people can experience the exact same event, and one person will say, oh, that was awful, I'm glad it's over, and then the other person can have more long-term effects of that. So it's all dependent on the individual. And that's why I say traumatic events by their very nature are dependent on how we perceive them, and that is different. They're also dependent on our development and our culture. Culture plays a strong role in how the meanings we attach to certain events. You know, how does our culture view, for instance, how does culture view mental illness? How does culture view the treatment of women in a home? We have societies where women really are more thought of as things than people. And so some of the trauma that those individuals may experience may be very different from that culture versus how they would be in the culture I grew up in. And ultimately, any long-lasting adverse effects of that event. That's a critical impact and critical component of the trauma. Our ability to cope with that event. Sometimes if we already have existing traumas that we're trying to deal with, one more traumatic event can put us over the edge. The more stressed I am, I respond to things very differently than if I'm calm. The more stressed I am, the more I'm like to react to things in ways and not make good decisions and be able to judge things well. So that's one thing of that. The degree of support. We all know that, you know, a strong support system can be very helpful for whatever problem we have. The degree of support we have to stay with us through that and be with us and support us through that is critical. Any altering of our neurobiological makeup can have an effect on that. Again, you know, the longer you have to, your brain has to deal with these traumatic events, the more likely it is to be impacted and impaired. And then that has a direct impact on our ongoing health and our well-being. So what happens in traumatic events is these experiences get triggered throughout our lifespan. And trigger isn't the horse on the right. A trigger in this instance is a conditioned response that happens automatically when we're faced with some stimuli associated with an experience. Example, you're driving down the road and a song comes on the radio that you remember from a particular event, for me one summer, or a particularly a boyfriend that I had then, and I hear this song and right away I go right back to that. Smelling bread for me, I drive by a bakery to get to work and I smell that every day and it reminds me of my grandmother. Those are things that just happen automatically when we're faced with these events. So when someone is triggered, they're seeing, feeling, hearing, all the senses get activated, and that tells us that it sets off our brain's alarm system. And then we have to assess if there's current danger, and if there is, then the brain just shuts into whatever it needs to do to help us. The problem with that is when people are experiencing this versus me remembering my grandmother and baking bread, and traumatic events when that happens, it's as if the person is reliving that event. So the present and the past become confused, and they experience it as if it's happening now versus me remembering it as being a particularly pleasant or a particularly unpleasant event. So that's the difference, and this is why we say trauma is truly a disorder of the brain. So we're talking about trauma-informed care and how we incorporate what we know of trauma back into how we provide services and supports in our community. So it's a paradigm shift, and this shift requires us to move away from things like what's wrong with you to what's happened to you. So we reframe our question. And there are some domains in this that we look at. For instance, early screening and comprehensive assessment. We should be assessing everybody that comes into our system for traumatic events. It should be routine in how we do that. It also has to be culturally sensitive and relevant. Consumer-driven care and services. Our entire world in health care is changing now from what it used to be when I started. So we're doing a lot more work around patients. We're talking about patient-centered care and all of that. Well, that's consumer-driven. That means the care and the services are consumer-driven. My pharmacy now is I can just go place an order for what I want and they'll bring it to the curb. That's really cool. I don't even have to get out of the car. That's consumer-driven. We have a trauma-informed and educated workforce. People need to understand. The entire workforce needs to understand about trauma. So we need to increase the awareness, the knowledge, and skills of our workforce so that we implement care services and policies that, in fact, don't re-traumatize. Evidence-based practices. We all hear about that all the time. We're all moving to evidence-based practices. And so that's making the skills of our workforce deliver treatment in such a way that we know works, that there's evidence or emerging best practices. And we talk about things like trauma-focused CBT, and we talk about, CBT in general. We talk about different kinds of models. So shared decision-making, collaborative decision-making, these are all evidence-based practices. What do our environments look like? Are they safe? Are they secure? Do they allow people to feel comfortable, or do we have things in our environment that tend to be less welcoming? Don't do this. Don't do this. Here's a sign. Here's a sign. Are we driven by signs, or is our environment a place where people could go and feel safe and trust, and a place that's designed for healing? Community outreach partnership building, it takes everybody. We all have to understand how we reach out to people in our communities to provide services and supports, our availability, I say the right services and supports to the right people at the right time. And then continually looking at ourselves and our performance to say, where have we done well and what can we improve in order to provide the best care and services that we can for these individuals. It is a culture shift, and you're looking at, again, awareness. Everybody understands. In my organization, we train 100% of our staff on trauma-informed care, including the janitors. And when I first came to Prestera and I said, this is what we have to do, people said, the janitors? You want to train the janitors in trauma-informed care? And I said, absolutely, because that janitor sees everybody every day. And many of the individuals we serve talk to those folks. So they need to understand when they see these things, they interact with folks, what that means. Ensuring safety, we're talking physical and emotional. Being trustworthy and transparent. These individuals have a difficult time trusting. So what we have to do for them, and it doesn't take long for them to trust us even less, to gain the trust of someone who doesn't trust easily is a monumental task. We have to be very careful then that we don't blow it, because it's, once lost, it's hard to get back. And these are individuals that haven't had a lot of trustworthy folks in their lives, perhaps. So it also means making tasks clear and maintaining appropriate boundaries. Things can't be confusing or seem to be secretive or manipulative. Voice and choice is driving healthcare today. prioritizing choice and control, and we're moving our whole system to be able to respond to that. And we've not always done that. Collaboration and mutuality. It is sharing power with consumers, seeing consumers as their own experts, valuing their perception, valuing the things they say versus I'm the expert, you're not, you just need to do what I tell you to do and you're going to be fine. That's pretty offensive. I've been in those situations where I've had that happen to me, and I did not have a good experience there, and frequently don't go back to places that do that. So that is an important part, and ultimately this is about empowerment. This is prioritizing empowerment, teaching people how to respond to their environment, giving them the skills and giving them the control. At the end of the day, you are the only one that can change you. And we know that with our consumers as well. So it's empowering them because many of these folks feel powerless, and that's a real problem for them. So the more power we give them, now we may have to put some parameters around that, particularly with children. But a lot of this is about helping people learn to take care of themselves in more healthy and socially acceptable ways. So in conclusion, what is trauma-informed care? It's a strengths-based approach grounded on the understanding of the impact of trauma, and understanding that trauma can in fact have significant physical, behavioral, emotional, and social impact for providers and survivors, and to help them begin to build a sense of control and empowerment. And organizations, as a trauma-informed organization, I have the responsibility to look at my organization and train my staff on trauma, to implement trauma-informed services and practices, to look at the policies of our organization and say, what in this policy is going to re-traumatize these individuals? Because policies are designed for a reason. But are they designed to protect the individuals we serve and our staff, or are they designed for us just to create a system to reinvent itself? So as an organization, there are many things organizations can do to look at themselves and reinvent themselves, or just change the way we do business in such a way that we are providing better service and better support for these many individuals who have experienced significant trauma in their lives. You have resources. There are several slides of resources on this presentation, but if you just Google traumatic experiences and trauma and traumatic stress, the ACE study, you can find it all over the internet. Lots of great resources out there if you're interested in learning more. So I think my time is up, and if I kept it to it, I'm really amazed. And I thank you all so much for sharing a part of your afternoon with me. I hope some of the things I've said are meaningful to you. Some of you may have even thought, oh, I know somebody just like that. If that is the case, then I'm very glad, and I wish you all a very happy afternoon.
Well, thank you so much, Karen. I think there was just so much great insight and information. I just thought of so many circumstances that we can see in healthcare, in no matter what setting that we're doing in home health. I think that we can look at the 6 o'clock news and apply not only the natural disasters that continue to occur, but thinking about the refugee crisis and how that is going to change in the next 5, 10 years, even for us in the United States. I think there was great insight in thinking about how for home health agencies, for example, I think that awareness that you mentioned, Karen, really is the key, and that was the idea, the introduction for this intro on trauma today, is that as clinicians, that we start to understand and ask questions and listen more for perhaps some of the underlying situations that may have occurred. We develop trust. We ask questions about, as they grew up, different things that there are clues there that we could learn to discover and to bring up for discussion. And I think, getting social worker referrals and working on stress management, and then tying that all into disease management. I just had lots of thoughts today as you talked about that. We've been working on our diabetes best practice intervention package that comes out May 2nd, the updated version. And, getting a chronic disease diagnosis is a stressor in itself, and it is a complex stress and trauma on top of that. And we know that depression, it goes hand in hand with those chronic diseases. And then we talk about diabetics that end up having to go to the hospital, perhaps the threat of amputations. So I just see chronic disease wraps more and more traumatic crises around the patient.
I think that's exactly right. And what this does is when you begin to look at individuals through a trauma lens, which is what I call it, it inherently changes the way we look at people and how we look at people in different ways. I'll use substance abuse, for instance. How do we look at individuals with substance abuse problems when we know very well that a number of them began using to self-medicate? So looking at things through a trauma lens inherently changes the way we view people. And for me, I can just speak for me and some of the agencies I've worked for, it changed the way we did business. Because we tried to really take that into account, and we began to look at our policies and say, what is it? Who is this for? Is this for individuals we serve, or is this we want to do something just for us? And how does that impact those that we serve? So it does cause us, exactly what you say, to reframe how we look at things.
Good. Now, we do have one question that we'll take, and then we have to move on to the other slides. And this comes from Carol. Do you know of any other specific research issues of adoptees from countries other than the United States, such as Russia, and the incidence of behavioral health issues? And some of those countries have issues with parents having substance abuse disorders or poor orphanages. To tell you the truth, that isn't an area that I work with a whole lot. Although we certainly do have some individuals in West Virginia from refugees. If you Google trauma and refugees, and if you Google other countries, you can find it. I can't think of anything right now that comes to mind. But I have seen several research studies and some work on that in the past, but I can't think of any citation right now that is directly to that. But if you look at war-torn countries and you Google some of those keywords, you'll be able to get some things, Carol. Great, great. We're going to hit the other slides here first because we're running short on time. There are some resources, HHQI resource on underserved populations that is available for you. We also have, let me get, sorry, my slides to move here. There we go. Now the continuing education. There are 2 slides here, plus when you leave the presentation, you'll land on the page that will provide information for you too. You have to go to HHQI University, and it's on the slide that's linked, plus will be on the side, and I just put it into the chat. In the university, you'll have to register if you've never registered for a course. It's all free. And you only ask like 4 questions: your name, your organization, what state, and what discipline you are. We have free continuing education credits for 1.5 hours for nursing as well as social workers. Now, social worker, this is the first time we've offered this in many years, and this is through the National Association of Social Workers, and they are accepted in many of the states, and I have also provided that link for you if you want to check to see if your state is there, or you'll know that specifically. The requirements are to watch, and you've already done this 1-hour course, our 1-hour webinar. So when you get into the course, then you'll register for the course. When you get to the part that says listen to the webinar, unless you already have, well, you all have already listened to the webinar. So anyone that could not attend today can still take the course by listening to the webinar and then completing the course, a post-test, and an evaluation. Then you can download and print your certificate. We have a link of resources there available for you, and always contact us at HHQI if there are any issues. Here are the steps for doing that. You have to register, as I mentioned just a minute ago, on the university. You then look for the long-term negative effects of trauma course. And it's going to be located in the general course catalog. There's a catalog. We have almost 30 courses that are available. They're all free. But you can find the general one will be the easiest way for you to find this course. You would click on Enroll, click on My Account, and then you're going to find the green icon. The instructions are spelled out on the website that you're going to land on or on the handout. So you can take your time and work through this. You need to do lesson 1, which is going to include the post-test, and then you will also have to do lesson 2, which is the evaluation. It's separate with a reflective question. And then once you have completed both of those, you will can go back to your account, and when you go to My Account, your certificate will be on your left side that you can print off. But again, if you have any issues, please contact us. I also just quickly, I know we're over the hour, our next UP networking event is July 21st on delivering cultural competent care, a 365 approach, really looking at some health disparities, especially economics for patients. We also have a national webinar that's going to be open to the public to register starting next Wednesday, Patient Safety Culture, a Foundation for a QAPI Program. And this is going to be by Tina Hilmes, and this is going to be on May 17th at 2 p.m. But you can start to register next week. It should be an excellent presentation getting us ready for QAPI, and safety is all written throughout the draft CLPs. And that brings us to our last slide, and I want to thank everyone for attending today. I thank so much for Karen for the wonderful presentation. I hope that you take a lot of the information and really think about how you can apply that and spread that within your organization. So thank you again.